Профессор Карлос Дасмундис из Бельгии нам даст замечательный доклад, я уверен.
Thank you very much. Thank you very much to invite me here today. Thank you, Alexander, to invite me in this beautiful congress. I was following the beautiful presentation before me. I hope I will keep the high level of this congress. Now, I look from there. My presentation is, of course, try to get some practical issue out of channelopathy. This is actually the mechanism, let's say, is the all mechanisms are involved in all channelopathy. Channelopathy is a big chapter. There are many issues over there. There are many questions do not answer. And one of the points is one of my mentors, is Pedro Brugada, always told me that idiopathic VF is not a diagnosis, but is a challenge. So the point is that every time you want to give idiopathic VF diagnosis, you have to be sure that you check every possibility and every possible diagnosis. Channelopathy, one of them. These are the list of channelopathy I will talk today. If I will start from long QT, all cardiology love long QT because it's one of the few cases where the genotype is fit with the phenotype. So you can predict the result of a genetic test looking at your phenotype. And that is the only way where geneticists and cardiologists, they go well together, they like each other and do not fight on table, but that is the few case because long QT is covering not all of your case of VF or sudden death or anyway your case of channelopathy. As you can see here, there is one big question in the hand. Is long QT3, as it was shown before, is not a typical potassium channel mutation, but it's sodium channel. And when you go on sodium channel, you open a big chapter. And that's the reason that long QT3 is overlapping often with Brugada syndrome. And that's the big question because there are many cases where you have a positive pharmacologic test in Brugada syndrome and still you have a long QT pattern on electrocardiogram. So what do for that? Because the mechanism should be sodium channel, but the reaction on the electricity in the heart is different. That's the point that when you talk about long QT, that's the mechanism. And the mechanisms are very clear, and you should know them, because if you want to treat the patient, if you do not start from mechanism, you will never succeed, because they are not react like a normal ischemic VT. They are not based on what we know about ventricular fibrillation. Now, as you can see here, as I just told you, potassium and sodium are most involved, but still they're not covered on long QT, and as was shown before, I will show later there are many long QT that are based on other mutation and based on few borderline mechanisms. But the fact that the genotype and the phenotype, they are strictly and consistent, they allow us to have 3 levels of stratification. You will find only in long QT a clear intermediate risk, because that was clear was possible to calculate in a stratification of the risk of this patient because the phenotype and the genotype are quite consistent. So the middle risk exists actually only in long QT. All of people study on the channelopathy, they try to fit this kind of stratification risk in all other channelopathy, but until now it's impossible because they are more complex, because the genotype and the phenotype, they don't fit so easy. Of course, when you have a high-risk patient, you should consider protection by an ICD. What I always told to my patient, an ICD, it's like the airbag of your car. So you buy the car with a airbag, but your aim is do not use it. So sometimes when you have a patient where you challenge with them with the electrical storming, or you have several VF or VT, you should do something more, because implant an ICD will not be a solution, and the quality of life will be reduced if they have continuous shock on event during the month. So the point is that combined with the drugs is one of the most known in long QT. Of course, the beta blocker is one of the most used. As discussed this morning, was also sympathectomy, one of the therapy that was considered in long QT in the beginning. We saw that it was, remember this morning, that sympathectomy on the right side is a pro-arrhythmogenic. Only the sympathectomy on the left side should be considered in long QT. At the moment, we perform this only in patients with high risk, with documented sudden death, or with repetitive VF episode. One of the other points in long QT that not many people does, and that's I'm a little bit disappointed about be so easy to implant a subcutaneous ICD in long QT, is that maintain the high heart rate in the atrium, so maintain a sinus rate around 65, 70 is preventing extreme bradycardia. And extreme bradycardia is a facilitate VF episode. So do not underestimate the advantage to have a dual chamber ICD in this patient, because sometimes to maintain a heart rate above 60 beats per minute could be prevent your VF episode. Of course, the guideline recommended in this case, as you can see, everybody knows, they are even older guidelines, but are confirmed with the new one, the implantation of ICD in high risk. But one point also is that do not forget that channelopathy is not only about ventricular arrhythmias, it's also about atrial arrhythmias. And that's the reason that in most of the recommendation, the programmation of ICD is specific for this patient. It doesn't fit with the patient with ischemic disease, because they have high risk of high atrial arrhythmias, like ventricular fibrillation, atrial tachycardia, atrial flutter. And that's the reason that your programmation should be selective on the VF zone, and should be also prolonging the detection period, because these patients are active, they are young, and they move. So doing sport induce even sinus tachycardia. They can be underdetected and maybe misdiagnosed by the device and provoking inappropriate shock. Inappropriate shock reduce the quality of life and increase the risk of mortality in all patients. As I told you, sympathectomy should be considered. That is something you do together with the surgeons. Can be performed quite safe. They are young people. They recover quite easy because they do not have long disease correlated. They always have they are almost time healthy people if you do not consider channelopathy. And of course, this procedure is quite safe in this category of patients. It shows in many studies that can improve the quality of life and reduce the risk of ventricular fibrillation. That's what I told you. Do not forget that long QT is also a disease that is spread around with many other mutations, and there are at the moment 15, but I'm not up to date because I think we are going up, and maybe somebody can correct me to date, but we are really double these numbers. So there are many overlapping situations where you can have a long QT. But then again, you can have a short QT, the other way around. So you have too short refractory period, and that's also a risk. So the balance is always the good way. If you unbalance the situation when you have a long QT or short QT, you have always risk of arrhythmias. Ventricular arrhythmias is always the risk in this patient. The problem is that short QT is not well diagnosed like a long QT. There is a misdiagnosis often in a short QT because not many people care, and most of the machine automatically diagnoses with electrocardiogram that are designed for surgeons, not for cardiologists. But the point is, these machines, they do not alarm when there is a short QT. They alarm only when there is a long QT. So many people, they do not care, or they do not see. Because most of these people you find on your pre-diagnosis for, I don't know, appendicectomy or any kind of surgery, they send you your HCG. As a cardiologist, you have to sign and check if it's normal. You don't know the patient, you never saw the patient. And then you are faced maybe sometimes with a long QT or short QT. These are typical way you find this patient. And unfortunately, you have to go through. You have to go through for one single reason. It's not responsibility only for this patient. When you challenge with the channelopathy, you are responsible for all family. And all family means that this patient maybe doesn't need any treatment, but you can easily find in a family an high-risk person that was not yet seen by a doctor, and you can predict and save their life, maybe to implant an ICD or to make a right diagnosis. So when you see a channelopathy, do not think about the patient, think about the family, and that's changed completely the algorithm. Why you have to screen a woman of 95-year-old coming for a pacemaker with long QT without any other reason? Because these women have grandchildren. And grandchildren, they can be high risk. So the point that the first patient can present to you, it happened to us, 85-year pacemaker implantation, paroxysmal third-degree block, and baseline long QT. She survived all her life. She will never receive an ICD, of course. She received a pacemaker because she needs. But the point is these women open a diagnosis of whole her family, and she has, I tell you, 25 grandchildren. So the point that you are responsible for the family, you're not responsible for the patient. So every time you see an HCG that can be suspicious, please go forward for a diagnosis. The fact that these diseases there is a feeling for everybody they are rare is because we don't search for that. And I tell you, there are many misunderstandings and misdiagnoses done because the people don't want to look on it. The short QT, of course, is again, unfortunately, I can show you there is an overlapping with. These are the 5 short QT, the most common. And as you can see here, again, you have I show you, sorry. there is an overlapping with, it's a slide after. So there is an overlapping with other channelopathy. In a short QT, as you can see, the mechanism, you have a PVC on the QT time, and then you have induction of polymorphic VT or the ventricular fibrillation. That's a typical situation. The drugs that were tried, I mean, in the short QT, there are no trial proving any randomized trial proving any treatment. There are short case report, series of patients. We know in many of the disease when you have depolarization or even some repolarization problem, isoproterenol can help you to reduce the risk of ventricular fibrillation or reduce the electrical storm. Often in Brugada or in short QT, we use isoproterenol to try to stop the electrical storm. Quinidine, it's a drug. Be careful because it's quite dangerous. Many of the patients cannot stand the drugs because it gives a lot of gastrointestinal problem. And on the long term, they can provoke, I mean, actually is a switch off all electrical system of the heart. And that's on the long term is not really the best option for the patient, but sometimes can help you to go out of the electrical storm. The best way to go out of an electrical storm in all channelopathy is to get patient in general anesthesia. If you put in deep sleep a patient, you reduce all effect of the vagal and the parasympathetic and sympathetic system, and often you can stabilize the patient. And then the moment that the patient is stable, is sleeping, then you can figure out what you have to do and which way you have to treat the best. That's my advice. Most of the time it works. I never have patient put in sleep, in a deep sleep, that they didn't stop with the ventricular fibrillation. Flecainide, ibotolide, quinidine, there are also drugs tried in a short QT. Actually, they prevent a little bit the episode, but of course, none of the drugs prevent the implantation of an ICD. In short QT today, we do not have any data proving any kind of ablation of reduction of or improving or long QT by electrical radiofrequency or any kind of treatment. So at the moment, you have to be careful when you implant an ICD because in short QT, like in long QT, you have a T over sensing, and then you should consider the machine have an open window for a T sensing because it's very easy, like in Brugada, to have an over sensing, to have inappropriate shock even in sinus sleep. Just show you the overlapping. This you see, there is a patient with a short QT, and then we perform an Ashmalin test, Aymalin test, or I don't know how you say in Russian, but the point is that one of the drugs to use to unmask Brugada syndrome. And as you can see here, it's beautiful, the pattern of type 1 Brugada syndrome is coming out during Ashmalin test in a patient with a short QT on the baseline. So this is a typical example of overlapping on syndrome. And that's what I want to show you. The 4 and the 5th, they have the same pattern and the similar on the overlapping on Brugada syndrome. So it's not even easy to decide which channelopathy you are deal with sometime with the patient because you have often overlapping, and that's also the difficult with the genetist. The way we solve the problem was discussed before. We do perform outpatient clinic together with the genetist. So I'm in the same place, we study the patient together, I give my version of the situation, and the genetist can give his version. But anyway, we find an agreement with the patient together, and we explain all part, and that was the only way to get out of this conflict. But I know, I mean, I live in Belgium, that is the same population of Moscow. You live in Russia, that is half of the world, so probably you have another problem. The question is that another channelopathy, actually it's not the pure channelopathy, but it's still considered in that family, is a catecholaminergic polymorphic ventricular tachycardia. Now, this is a big challenge. Unfortunately, this is has a very bad outcome for the patient, and it's often induced by exercise. So you have this patient, young people, often they during exercise, if you do perform an exercise test in these people, they have this reaction of the exercise and the adrenaline effect. What do with that? So the first is that they always present with syncope, aborted sudden death, and then during exercise, or unfortunately sometimes we have one patient before the exam in university, he get drop, attack, and it was bring on the emergency room, and that we could reproduce the episode because sometimes when they arrive you don't have any sign. Often in this patient, in baseline HEG, do not have any sign at all. And often when they sleep or they don't have any other emotional situation, they do not have any problem. Contrary of the other channelopathy, long QT, there is some case that they can have an episode only in the night. In Brugada syndrome, often with the hypervagal effect during the night, you have a VF episode. In this case, is all the other way around. They react most on the adrenergic insult. The mechanism around, there are many theories. I mean, there is the sarcoplasmatic reticulum membrana, but then I will not be in details because it will not help you to the choose of the treatment. But then there is a reference if you want to go deep. By the way, this is not even in full agreement about this disease, and there are few mutations that are not fit with this theory. The drugs trial, again, we don't have a randomized trial because there are not many patients for single center. There are no international registry to collect these patients, so we do not have more than this data about use a beta blocker. A beta blocker and was used nadolol and carvedilol. There is a specific reaction by the mutation of AR2 that is where the carvedilol can have a better effect, and it's one of the cases where working with the genetist it can give you a better option for a clinical management of your patient. Like in long QT, you can easily figure out how to follow your patient if you know which mutation is involved. Verapamil has some effect, but actually there is no longer-term efficacy. Verapamil was used to reduce the effect during exercise to try to contain the ventricular fibrillation or the polymorphic VT, and that was not proven on the long-term effect. There are some study again on the genetic proof that the flecainide can be a direct suppressor when you have a RI-R2 receptor mutation, and the class 1 are antiarrhythmics. Again, for this study, we have only few cases. There are no randomized study, and actually they are directly based on the mechanism of the mutation. So if you can prove that this mutation is in charge with the patient, probably flecainide could be a big option. But still, all of them, they do not prove that you can avoid to implant an ICD. In this patient, there are studies, and actually this study is randomized, where the left cardiac sympathectomy derivation prove the improve quality of life. Sorry. And that is the Kaplan-Meier of the patient. So before and after, as you can see here, the survival rate and the event rate is strongly improved with the sympathectomy in this patient. And that makes sense. If you think about the mechanism behind, that makes more sense to me in the long QT. But anyway, in this patient, it's suggested and offer what we do. We do perform during implantation of ICD, because we do perform an implantation of ICD subcostal. And so in thoracoscopic, we enter, we place the ICD subcostal, the epicardial lead. And in that case, we have in front of us the ganglia, and we can perform direct sympathectomy. Combine the two interventions, reduce the risk of complication, because you can have two advantages in once. That is of course the point, that when you have a patient that it's difficult to prove that there is a control of therapy because there are no randomized studies. So I think none of a cardiology will feel confident to treat only the patient with drugs that do not give an ICD. But in some case you can avoid that, but it's a specific case, and I think if you do not have a high experience in this kind of disease, it's difficult to figure out which are the patients that can be avoided with ICD. So I do not give you this advice out there, but can be discussed in a specific case, maybe with the genetist or with specialist center. There is a test. Of course, if you do epinephrine test, it's a little bit like Ashwelin test in Brugada syndrome. Epinephrine test can induce the polymorphic ventricular tachycardia. And then epinephrine test was used to induce the tachycardia to perform an ablation, because in this case was always, so there was a kind of pattern, there was a kind of PVC induced always in the beginning, as you can see here. And this PVC is coming often from the Purkinje fiber, as was shown before my presentation. And there are some ablation proving that if you ablate this region where the PVC is coming from, you can contain the episode of ventricular fibrillation. There are no studies randomized to proving that can avoid the implantation of ICD, but at least you can improve the quality of life of the patient. Again, I told you, the airbag of your car, you don't want to use it, so you have to do everything to prevent that the patient get a shock. And that could be one of the option if drugs not working and the patient has a bad quality of life due to the several ICD shock. Again, just to show you how complex it is, you have several mutation pointing the CPVT. And again, you have some CPVT that is overlapping with long QT4 and other channelopathy. So again, it's not so easy to deal with them, and it's not so easy also to define which one the patient deal with. Early repolarization syndrome, that's just to give you some overview of a history of early repolarization syndrome, is something that was saw from a very early stage. And then, as you see, in 1936, somebody already saw that there was something strange on the electrocardiogram, and something was related with arrhythmic event. Now, I have to tell you, we did several studies, and if you want to do a study your center, it's quite easy. If you take all young people, actually we took a football team of children, and we took the HEG, all of them, and unfortunately I can tell you 95% of them, they show early repolarization. None of them has sudden death, none of them have family history of sudden death. So early repolarization is quite often in young people as electrocardiogram pattern, and it's quite often in sportive people. So it's very big challenge to make a diagnosis of this, and it's very easy to overdiagnose this syndrome, because in all of young people, I mean, the electrocardiogram on the young people of sportive, they always show an early repolarization. But that's normal because of the hypervagal tone. Now, the point is that when you have combined, oh, sorry, I destroy everything. No. I know. This is a very dangerous button here. So, in case where you have aborted sudden death or this famous idiopathic ventricular fibrillation, then you can consider that if you have an early repolarization on the HEG, you can consider this patient maybe they deal with this disease. And that was a study of Eisegehr that proved that this patient can be ablate. Now, ablate, that's a definition of early repolarization. As you can see, is the, I'm sorry for the layout of the slide. As you can see, there is a specific pattern that can be visualized and detect on the electrocardiogram baseline. Don't remember that this patient, that they have a sudden cardiac death, most of the time they have a history of sudden cardiac death, and they have, of course, history of syncope. It's not everybody coming to you with an electrocardiogram like that, especially if you have an intensive sporter or an athlete. They often show this electrocardiogram. They do not have sudden death. It's difficult, of course, challenge with these people, because when they come to you and you have to give the authorization to perform intensive sport, it's always a challenge, but this is not enough to give the diagnosis of early repolarization syndrome. You need to have, most of the time, the first signal is the history of sudden death in the family or history of syncope. Then you can start. Then, of course, the risk of this patient when you have a history of sudden death in the family is increasing the risk of sudden death in the patient himself. And, of course, the prevalence is very high of VF in this patient. The point is that you can have this stratification risk, and it's based on how bad is the early repolarization. Because in this case, fortunately for you, the worst is the case, the worst is the electrocardiogram pattern. So at least when you have a very high-risk patient, the electrocardiogram doesn't look like a normal sportive guy. So that it could be the first one. The electrocardiogram in high-risk patient has a very clear G-way and a clear early repolarization pattern. The diagnosis, of course, is quite easy, but the problem is that, of course, when you have aborted sudden death, it's easy to diagnose that the patient has high risk of sudden death, because by definition, a patient reanimated has high risk to be reanimated again. But the point is that in most of the patients, the history of the family could be clear and could be clarified to you, the diagnosis of the patient. The point is you should never overdiagnose this, because it's very common a pattern in electrocardiogram. And the ablation of Eisegehr was based, like in a CPVT, was based on the fact that if you find the early PVC that induced the VF, it could be the region that you have to ablate, and you can control the episode of ventricular fibrillation. Again, there are no randomized studies to prove that you should not give an ICD. And by the way, these PVC, sometimes, more often, they are on the Purkinje area, but sometimes they are out of the Purkinje area, and you never can prove that they not come from somewhere else in the long follow-up of the patient. So the ablation can improve the quality of life of the patient, but should not be alternative of implantation ICD. These are the theory behind. Of course, the early repolarization is reducing is always about the actual potential. If you do not have enough plateau, if you have too much refractory period or too less refractory period, that's always your problem. You should be perfectly in the middle. You should be in a good balance, because otherwise you can always induce ventricular fibrillation. That's what we saw in a short QT, long QT. Early repolarization is actually this notch that you see in an action potential is creating a kind of gap when you have an electrical gap between the membrane of your cell, and then it becomes more arrhythmogenic, and then a PVC, as you can see in epicardial 1 and 2, the traces down there, they show in that and a PVC can easily induce a ventricular fibrillation because you do not have a refractory period in that moment, and the notch that you see in the action potential here is promoting actually the ventricular fibrillation. Because the pathophysiology is similar, it doesn't surprise that it's similar PVC, CPVT, sorry, beta blocker, and similar also to Brugada syndrome. Beta blocker, or anyway, beta-adrenergic activation, isoproterenol, could be effective to suppress these arrhythmogenic events. So when you have a patient that's coming electrical storm, or you have to control them in emergency room, consider this kind of therapy could be helpful, but of course you need to have a diagnosis before. If it's coming somebody in electrical storm out of the blue and you do not have any idea, it's very difficult to choose for these drugs, I believe, because it's in many of other diseases they promote the ventricular fibrillation. And that's also the big challenge in channelopathy. Now, this is, of course, quinidine can decrease the recurrence of VF, but be careful because quinidine will always be mentioned in all channelopathy because quinidine is like to use a bazooka to kill a fly because you really switch off all electrical system of the heart, and it's quite unfair that you have still some activity. Consider the patient become completely pacemaker dependent. It's the mechanical activity of the heart is reduced. We don't know what is the effect on the long term because it could be also a mechanical effect on the long term. It can promote heart failure. That was never proven, was never studied. And by the way, it can provoke, if you give these drugs without any device, it can easily provoke a third-degree V block. So the patient can die because of systole or third-degree block if he doesn't have any device in backup. So quinidine will always be performed, but do not think that it's your golden weapon because it's not. It's like what I believe it's like a corderon in atrial fibrillation. You are shooting so hard that maybe you can get it. But on a long term, these are not drugs that you should use it. Isoproterenol infusion is something we use often, and it was able to suppress the electrical storm in all patients in this small study. In our experience also is something that we use on the first line. The problem is that when you perform any study, when you perform any investigation in a channelopathy, you should perform in a protect area. So we do that in a cath lab. That's mandatory because in all ashwalin we do, in all epinephrine we do, we have always one of 1,000 patients that need to be reanimated, and he has to go in external pump circulation for 1 hour because before he gets cleaned up of the drug. So it's not so often. Sometimes shock with a cardioverter with a defibrillator is not enough. Sometimes we have to really put an ECMO and external circulation before the patient can recover completely from the effect of the electrical storm, just induced by epinephrine or induced by ashwalin test. So it's not something you have to do in outpatient clinic. It's not something you have to do in not protect area. Again, here, if of course you have electrical storm, induced isoproterenol could be helped during this evocative test. That's, of course, this is another study that proving how difficult it is. This was a 7 patient with the GA syndromes. Unfortunately, if you look at the paper quite carefully, 5 patients of them, they have also Brugada syndrome. So actually only 2 of them was a really early repolarization syndrome, pure. And they have, of course, several ICD shock and due by BF. And they combine the therapy with citolazone and bepredil, but the problem that there are only 7 patients, actually the only 2 specific of early repolarization syndrome, and they was able and do not have a recurrence of VF during the follow-up. This is not data they can support, but it's something that can have alternative if you are looking for really and control that to this patient. And ICD, of course, is indicated on all these patients, and there is no risk stratification because the data and the study around are not so, the registry are not so big to give a clear risk stratification. I will try to go fast because otherwise you fall in sleep. There is a way, again, here to perform what I told you before with this ablation. That's, of course, you can find this PVC that is actually the is a PVC that is occurrence before an AVF episode. And if you get the target of this PVC, as you can see in this case, is not on the Purkinje. As you can perform this PVC ablation, there is a reduction of the episode of ventricular fibrillation, but on the long-term follow-up, the data was not confirmed. So the PVC can come from another area and still, because the repolarization problem, they can still induce ventricular fibrillation. Brugada syndrome, just to know that I have the honor to lead the center. It was created by Pedro Brugada. So we have a huge experience in Brugada syndrome. We have one of the biggest database. And as I can show you, this was the first paper that the Brugada brothers, they wrote. And everything is wrote in the title was not true. Now, right bundle branch block, persistent ST elevation, and sudden cardiac death are not always present in all patients with Brugada syndrome. As you can see, the genotype in the picture upstairs, there are two brothers. You can have a genotype changing because you see the hair, but in the end, the phenotype is always coming back on the genotype. As you can see, both of them, they are bald. And then you can always figure out the situation. That is the first patient. The first patient was diagnosed with Brugada syndrome. It was a child, and in this case, is present this electrocardiogram during fever. That was the first way they saw this change. And the sister of him died on the 3 years old, was reanimated but was unsuccessful. And this child was reanimated 7 times before he came on the attention of Professor Brugada. And fortunately for him, he was sleeping between the mother and the father. The father was a military officer and was able to perform cardiac reanimation. And so he actually saved his life 7 times. When he came on attention, of course, he has this right bundle branch block, but we know on the follow-up that is not always present and is not mandatory. Unfortunately, the type 1 is not persistent, and that's a big drama because all of you maybe feel confident if they see a type 1, but I can tell you there are many HEG maybe pass over that they are Brugada syndrome and you don't know because the type 1 is not present at the time. We know that when the type 1 is present, the patient has a high risk to have an event. And then, unfortunately, there are also other situations that can simulate the Brugada pattern that they are not related on the disease. They can just present in a health situation, like, for example, petum excavatum is the pressure of RVOT that can provoke an V1, V2 changement, but the patient doesn't have a Brugada syndrome. Brugada syndrome is quite complex, and that's coming also from a genetic, because it's a disease that is polygenic, and today we always talk about one mutation, but at least there are several mutations about that. We don't know yet what is the cluster of mutation that is provoked Brugada syndrome, honestly. We know some mutation that is always present in Brugada syndrome, and the reason that we have repolarization and a depolarization problem is because probably Brugada syndrome is just an electrocardiogram pattern showing and a big family of channelopathy. As you can see that you can find also contradictory situation. You can have a shorter PVA duration, or you can have a AV block. You can have 6 sinus syndrome, but you can have atrial arrhythmias, like AV nodal tachycardia, AV nodal oriented tachycardia, or ventricular fibrillation, atrial fibrillation. So that's also the point that when you have a patient with Brugada syndrome, asymptomatic, it doesn't mean that it's finished. You should follow the patient because still can have atrial fibrillation, high risk to have atrial fibrillation, and we also saw that sometimes the cryptogenic stroke is the first presentation of Brugada syndrome, so we do perform Ashwelin test in all cryptogenic stroke, and we find out that a small percentage of them having Brugada syndrome, they do not need an ICD, but they have AFib, and asymptomatic AFib can be misdetected, and they can have this problem stroke. So the patient with the channelopathy, even if they are symptomatic, doesn't mean that they are not candidate of your attention, because all of them, they have high risk of atrial arrhythmias. All of them, they have high risk of conduction disease. So anytime you have an asymptomatic patient, you should see at least once a year or once every 2 years, or get contact, or anytime start the symptoms, because some of them will get a pacemaker maybe when they are 70, quite early, or some of them they have an ablation of AFib because they have atrial fibrillation in an early stage, or an AV nodal oriented tachycardia. So do not think only of ventricular fibrillation, because it's an electrical disease, and it's an electrical disease that is concerned all heart. I try to make the story short. One big mistake that Professor Brugada regrets is that in the consensus we talk about type 2 and type 3, but it doesn't mean there exists 3 types of syndrome. The syndrome is one. The syndrome is only the one that presents this pattern, and they are type 2, type 3, they are not, they're just two different types of electrocardiogram. They have nothing to do with the disease. They are very often a family member, and actually they are situations that they should suggest to perform an Ashmeling test. But the diagnosis is only one, and the syndrome is only one. So it's called type 1 because it was this misunderstanding during the consensus. Of course, they have a high risk of ventricular fibrillation. That's just to show you that during the follow-up, all our patients was followed by electrocardiogram, and they show that 35% of the patients, they lose the type 1 spontaneously. And it's enough to have one electrocardiogram, one precordial lead to perform the diagnosis. Just show you, a patient enter with an ICD, electrical storm. February 5th, he has this type 1 pattern. February 13, when he went home, the pattern disappeared. So just in few days. That's what's happened normally in this patient. So concentrate on the persistency of the type 1 is not the best way to treat Brugada syndrome. You have other paradox in Brugada syndrome. You have alternancy of the T-way. As you see, the microvolt T-way alternancy in this patient. As you see, every bit the T-way is negative, isoelectric, negative, isoelectric, and that is an alternancy of the endo-AP defect of the repolarization. Sorry. In this case, as I showed you before, ascent of G-way, as you can see, there is an Ashmeling test proving that is also Brugada syndrome, overlapping on the syndrome. In Brugada syndrome, something that is really independent, high-risk pattern is the fragmentation on the type 1. When you have fragmentation like this, is an independent factor of sudden death, even if the patient is asymptomatic. Often this patient, during an LP study, is inducible for VF, and you don't need to pay so fast. Actually, 2 extra steam in the second cycle could be enough, but this is an independent, the fragmentation in that case is an independent risk factor for this patient. And unfortunately, even the fragmentation itself is not a stable signal. As you can see, this patient during our follow-up with an ICD, at 55 every year we saw him back to check the ICD, and then you see the pattern of the electrocardiogram change, even the fragmentation itself is gone. 1 year after each other, and the pattern even come back without fragmentation after 2 years. So unfortunately, I cannot give you more than this advice, but it's nothing stable. It's a very dynamic disease, and it's more dynamic than long QT. Long QT, cardiologists, they love it because it's quite fixed. But this is very dynamic disease, and that's actually all pain that you get from this patient. The theory behind actually they don't fit to each other. We have a depolarization syndrome with a repolarization syndrome. I finished. And just to show you one score, we have a score stratification for this patient. We have this is the point that we give to stratify them. This is a Kaplan-Meier to show what is the outcome of this patient. Of course, when you have more than 2 points, you should give an ICD. It's published on European Heart Journal. And that is just to show you this slide, very nice. This we try to put on the line all event in patient with ICD high risk, just to try to see if there is a pattern to predict the event. And as you can see, there is not. As you can see, the cross is event 1, the round is event 2, and the triangular 3, and the square 4. And as you can see, there is no pattern, there is no way to predict it. And the red line, they are the change battery of the ICD. So the patient had 2 ICD. This is also a publication in American Journal. I will not talk about ablation because it was already discussed. Just one point to the ablation, that we perform the ablation in thoracoscopic approach. Probably some surgeons here will love it. And that's give better outcome for the patient. This is implantation of subcutaneous ICD that I show you, and that can be performed during the thoracoscopic approach or sympathectomy during long QT. This was a child who was done at that time. This is my conclusion. Search for the disease and be careful about the mechanism behind, because the only way you can figure out how to treat this patient, especially in VF. This is our team. And I want to point one. The guy in the middle is our cardiac surgeons. So that's the way that we work. We have one of rhythmology surgeons, and is in our team. Thank you very much. Thank you very much for inviting me here. Sorry for a long time.
Thank you very much for your presentation. Any questions?
Can I ask one question?
Yes, please.
You show in one slide importance of the filtration and ACG. What setting do you use usually for your ACG machine to better recognize this ACG phenomenon?
You talk about Brugada syndrome, probably, or all of them.
Any.
No, now
For practical questions.
no, I know. That's what we, for example, in Brugada syndrome, we do perform an Ashmelin also on the third intercostal space, not only on the fourth. So we move up our intercostal space. We are trying to use this new non-invasive or anyway high-density electrocardiogram to figure out if there is some data can be helpful to stratify the patient. At the moment, the HEG machine is setting on the normal way because we always did in that way. So to be able to compare the data on the past, we cannot change too much our HEG machine. So we still perform Ashmelin test with the 12 lead HEG, but we add a high density electrocardiogram actually to try to see all region. Of course, everything can show you the RVOT region can be helpful to clarify the diagnosis. What we prove, unfortunately, is that even one electrode between 4 on third and the consensus even talk about the second space, is one of them showing a pattern of Brugada syndrome is enough to have a diagnosis. So, I'm sorry. So that's what we do. We just move in Brugada syndrome. In other, for the long QT, I always perform a 3 electrocardiogram with the machine to be sure that the measurement of the QT is correct. I have to admit that the algorithm of the machine to calculate the QT is quite clear, but we can always confirm ourselves. And if you do a stress test, of course, one of the first dynamic effect of a long QT, that long QT doesn't short during the increase of heart rate. So if you give adrenaline test or just a stress test, if your QT stay longer, that's one of the proof that you are dealing with something not physiological, because normally when you have the reduction of a RR interval, the QT should follow. If the QT doesn't follow, so a stress test can be the next exam to figure out if the QT is normal or not. That's why my point. Yes,
May
please.
I ask? Actually, first, thank you for excellent presentation. And for me, it's very important what you are talking about long QT syndrome, because when I was talking about overusing of genetic test, it was exactly about QTC, because we have a lot of patients coming to us with QTC a bit longer than usually, but found on Holter monitoring, not at resting ECG. And for me, it's quite a problem because I cannot, deal with it somehow, because there is nothing in diagnostic criteria about detection of QT prolongation on Holter monitoring. But we have many cardiologists who really love this syndrome and send to us a lot of patients with QTC slightly increase found at Holter. What to do with it?
No, thank you for your question. Now, the point that we do not use the QT of the Holter to make a diagnosis, first. Second, we try to reproduce the long QT. So the point is that if you have a long QT, it should not be something you see once in the life of the patient. Is not reproducible. Means that an adrenaline test should be able to reproduce, and an exercise test could be able. The problem is that the cardiologists love long QT because the geneticists, they can give an answer, but they believe that is work like that. Actually, of course, we suggest always the way around. So you need to have a clinic to make an answer to make a question to the genetist. And in long QT, we do not trust anything else than 12 lead HEG that is based on that. All studies are based on normal 12 lead HEG, and eventually an adrenaline test to prove that QT doesn't short, or a stress test. But the Holter is not something that we use for, because many Holter, they have a derivate lead, so they are not 12 poor direct measurement of HEG, so they are most of the time they are 5 channel, and the QT is calculated by 5 vector, that they are not the traditional one. So often you can have a long QT based on the miss sensitivity of the device himself. And when you have 12 lead HEG, normally you should be trustable, but not many people use the 12 lead HEG, but use normally the 5 vector HEG. So that this QT is not helpful for making a diagnosis for sure. You're very welcome.
Thank you. Thank you so much.
Thank you.